Welcome you, sir. Before, yes, sir. Before I
just a small correction. I think my topic you have said different topic.
Pardon? Which topic, sir?
My topic is tibialis posterior dysfunction.
Function. Okay. Let me check for the couple of seconds, sir. 1 minute. Yes, sir. There are some technical issue. Yes, you are going to talk about the posterior tibial dysfunction, condition often overlooked and misdiagnosed.
Yes.
Sorry, getting started. Thank you. Sorry.
I'm the today's session. This is the last topic in the list. Yes.
Thank you, sir. So before we start with the session, I would like to introduce the speaker, Dr. Radhakrishnan Unnikrishnan. He has been recent publication in the journal Group Denture Q4 Clarivate Analysis and Web of Science. Is a stiff person syndrome benefited by the physical therapy intervention, previous work experience and clinical, and work as a consultant physiotherapist in the Best Hospital Private Limited and Kodambakkam. Thank you once again, sir. Welcome you for the session.
Thank you.
I think kindly give us a second to upload your PPT, sir.
Okay, no worries. Okay.
Sir, kindly wait for a second. Wait for a minute, sir. Yeah.
Yes. Thank you.
Thank you, sir. I kindly request the speaker to introduce briefly about himself.
Okay. A very good evening, I should say, or because I think everybody in the end of the day. So first of all, thanks for giving me this opportunity. I'm Radhakrishnan from Majma University, working here in Saudi Arabia. So I think even the doctor has given me a brief introduction. So I can proceed with my topic right now. Can I?
Yes, sir. We can proceed, sir. Yes, sir.
Okay. So today's topic, so I think because of time constraint, we are going to give a concise overlook about this state. That is, usually in the clinical practice, posterior tibial tendon dysfunction is often overlooked or misdiagnosed. Next slide. So according to the great sculptor Leonardo DaVinci, he said that foot is a masterpiece of engineering and work because we almost have 26 bones, 33 joints, 107 ligaments, and 19 muscles. So such a wonderful architect is the foot. So we have very complex functions. So we have to rule out and we have to know about that better. Next slide. Next slide, please. Yeah, often when we take about a patient comes to us with pain over the medial aspect of the ankle, we usually say that it might be plantar fasciitis, ligament injury, tarsal tunnel syndrome. But we often miss the posterior tibial dysfunction, which is also one of the major cause which may lead to many disabilities. Next slide. So today's goal of we will be seeing the overview of the functions of posterior tibialis and some steps in assessment of this tibialis tendon function and management for posterior tibialis tendon dysfunction, and recognize posterior tibialis tendon as one of the important conditions which we have to take care. Next. So the tibialis tendon dysfunction is a condition that leads to pain and walking disabilities. It is also the leading cause of acquired flat foot. So many researchers have proved it that it is one of the leading cause of flat foot. So this dysfunction is often not recognized early enough. So it is underdiagnosed and is not well understood. So it's very important to know about this posterior tibialis tendon dysfunction. Next slide. So prevalence, the statistic says there is about 3.3% to 10%. So it is very important for an early recognition and treatment to prevent the long-term consequences of this disorder. Next slide. So coming to the etiology, it is very important. See, there are very various causes like inflammatory, degenerative, functional, traumatic, and other risk factors. In inflammatory, we have the lupus, rheumatoid arthritis, Reiter syndrome, and in degenerative, tendon degeneration causes, and functional due to abnormal biomechanical forces, and because of trauma, maybe due to acute trauma, and other risk factors like diabetes. These all are the major causes for posterior tibialis dysfunction. Next slide, please. So what is the major important function? So to summarize, the most important function is this tibialis tendon is an important, powerful supination. So it will produce a supination of the hind foot and the plantar flexion of the ankle. And more important, it is plays a significant role in elevating the medial longitudinal arch. It provides an opportunity for the gastrocnemius to function with greater efficiency. So generally, it's very important to know about the function in its function in the gait, that it produces inversion at the subtalar joint and locks the transverse jaw in place, thus supporting the medial longitudinal arch, and it prevents it from collapsing during the gait. Next slide. So you can see the picture, the major pathomechanics associated when there is a dysfunction or rupture or weakness of this tendon. So mostly the medial longitudinal arch collapse. So what exactly happens is the subtalar joint everts, causing the heel to assume a valgus position. This is an important thing. There will be a valgus position of the heel, and then foot will abduct at the tanonavicular joint. So what happens as there is a change in the axis. So the heel assumed an increased valgus alignment. So over time, what happened because of this small position, there will be shortening of the Achilles tendon. So this will lead to even Achilles tendon contracture. Next slide. So there are many clinical features. So we have to be very careful when we are evaluating. So usually a patient will be presenting with the pain at the medial side of the ankle, swelling along the course of the tendon, and the sole, there will be pain in the soles of their shoes. And walking, you can see when you shoes, there will be more of wear and tear process, which you can see. And then the dysfunction acts progresses. The patient often report that patient cannot stand on their toes. It will be more weak, painful for them. And simple walking will also aggravate the pain. Next. So coming to the investigations, I told you about the tendon, how to investigate more. So any orthopedic, we'll start with the x-rays. So in the x-rays, I will tell you some of the important features which we have to see. So first important thing is calcaneal inclination angle. So this is a very clear angle which we are going to find from the calculation axis to the supporting surfaces. I can show you the picture in the next slide. Next slide, please, doctor. So in the next slide, you can see that there is an angle formed. So generally, will take in a weight-bearing radiograph. So there, the angle between the calcaneal thing and the horizontal surface. So generally, if the angle is 10 to 20 degrees, it may indicate the pes planus or flat foot. So medium, 20 to 30 degrees. And if it's higher, greater than or 30 degrees, then it may be indicator of pes cavus. That is exaggerated. arch. Next slide, doctor. So various other X-rays are also there. I will show you one by one the pictures. Can you move on to next slide? Yes, this is also one of the important angle, Mary's angle. So actually this angle should coincide. That is like a line joining the main center of the talus and the first metatarsal. Usually this angle should be 0 because in the normal foot it fuses. But if the angle is greater than 4° convex upward, then it might be pes cavus. Same way it is less. If it is dropped, then it is pes planus. Next slide. Same way, we also can see the height of the medial cuneiform bone from the floor. Normally, it should be 15 and 25 millimeter distance, but in the flat foot case, it will be reduced. Next slide. So coming to the ultrasound, so after X-ray, we are going to ultrasound. So we will take the ultrasound of the tendon. So usually if when there is a dysfunction, there will be thickening of this posterior tibialis tendon. So we'll get a heterogeneous hypoechoic texture. So we'll get a indication, which is a low-grade posterior tibialis tendon injury indication. So this will give you, I can show you the picture of the ultrasound in the next slide. Next slide, please, doctor. So you can see the arrow mark showing the picture, which will show you the tendon, the gray marks. So this is a normal tendon. The more important thing is the posterior tibialis tendon is angled at the area of the medial malleolus. So this will give us a less circulation to that tendon. That is one of the anatomical features. So that is one of the reason where it get mostly important area where it get injured and it will get affected also. Next slide, doctor. Next, from ultrasound for a higher thing, we'll go for MRI for more clear picture, and it will help us to know about the associated injuries also. If there is any ligament injuries or if there is any other fluid collection, it will be very clear for us. So we're going to see MRI. So the pictures are in the next slide. Kindly go to the next slide, doctor. I can show you some of the pictures of MRI. So you can see these are the pictures of posterior, the areas of the posterior tibial dysfunction. You can see the shadows. So next slide, doctor. See, this is a picture of the complete rupture where you can see the image. So of this tibial tendon where there is an injured tibialis tendon. Next, doctor. So coming to assessment, so as our target audience students today, so we'll start with the assessment. So usual subjective assessment, we'll take all the information of the history and other details from the patient, and we will generally check what is the we will inspect their soul, what is their complaint, we'll record their pain assessment through the VAS scale, we'll record all these subjective assessment. And then next slide. We will move on. So this is important. So from objective assessment on observation, what we are going to see. So generally, we will see for some swelling in the medial aspect of the ankle, and there will be an increased valgus angulation. So in the hind foot, that is very important. Then too many toes sign will be there. So I can show you what is too many toe sign in the next slide in the picture, which will be very clear that the lateral side of all the affected foot will be viewed behind. So can you go to next slide? I will show you what is too many toe sign. That is one of the important observation which you have to see. See, too many toe signs will be because of this excessive eversion. You can see that there will be too many toe sign, and then there will be a complete absence of medial longitudinal arch. Next slide. So on palpation, the posterior tibialis tendon should be palpated through its course along the medial side of the ankle. So we will check for any tenderness. There will be any problem in the lateral side of the foot. We may check. Next slide. On examination, we will check for the range of motion of the ankle joint and the subtalar joint, and we'll record the movement. And then we will check for the muscle length. The Achilles tendon should be assessed for the contractures. Usually I told you, because of the change in the position, there is more chances for the tightness of Achilles tendon. So we have to check for the muscle length of this Achilles tendon also. Next slide. So coming to the other important assessment is this Fees line. So you all are very much familiar with this. So we are going to draw a line from the medial malleolus to the plantar aspect of the mid TPS joint. So this line will tell us whether there is a level of navicular bone, whether it is dropped or it is in the normal level. So generally, we say that 30 to 90 degrees means it's about hyperpronated foot. Next slide. This is one of the important tests, and the research says that it has a very good sensitive indicator. So the various research done by Johnson et al., they've proved the sensitivity. So this is generally asking the patient to do a single heel raise with one foot unsupported and other foot you're going to do the heel raise. In that, we can see the affected hind foot will either remain in valgus abduction. So for the normal, you can see the picture. I've compared both normal and the abnormal foot. So the affected hind foot will either remain in the valgus abduction during the heel raise due to the failure of the posterior tibialis to invert it. So you can see that hind foot stays in the valgus abduction. That is something abnormal. Next slide. Same way, there is also a double leg heel raise test, which is also one of the important tests. We have done it. So you can see the same way in this test also. The affected hind foot will stay in valgus. So this is same. Before we are doing with a single leg, now we are doing with a double leg. Next slide. This is also one of the important tests called first metatarsal rise sign. So what we are going to do is we are going to passively rotate the tibia. We will do externally rotate the tibia, shin of the tibia. So in this position, what happened in case if there is any dysfunction associated with posterior tibialis or tibialis posterior, the first metatarsal will be lifted off. So this is also one of the important tests. Many researchers have done that and proved. So this test is also one of the indicator for us to prove the tibialis dysfunction. Next slide. So now we are going to, we saw the assessment. Now we are going to, with all these assessment, we are going to categorize the stages of tibialis dysfunction. So stage 1, stage 2, stage 3, and stage 4. So the stage 1 is just like tendon length is normal. There will be only mild pain. There will be tenderness. There will be swelling. There will not be much damage exactly to the tendon. But in stage 2, the tendon is elongated and the hind foot is in normal position and there will be swelling. And when you do, when we do about the single heel raise test, it becomes abnormal. So that is the difference between stage 1 and stage 2. The test will become abnormal. Same way in stage 3, you can see some of the degenerative changes and the tendon will be elongated and there is pain and there is fixed flat foot deformity. So this is important. From stage 3 onwards, the deformity starts. And stage 4, there is a valgus tilt of the thallus within the angle mortis, and there is a lateral tibiotalar degeneration. So the more degenerative changes is found in the stage 4. So now why this is very important? Because this staging is very important. Our management is depending on this stage. So now we are entering into the management section. So we will be more, our typical role, physical therapy role is more in stage 1 and stage 2. In stage 3 and stage 4, we will be more into the post-operative role, which is another broad area which we are not going to check today. So today we will see how can we tackle with the stage 1 and stage 2 dysfunction. Next slide. So I think now we are very near to the midnight. So this is one of the differential diagnosis which we have to see. So other than this, always we have to cross check before coming to the stages. We have to say whether there is any spring ligament complex, any injury to the ligament, any degenerative arthritis, or there is any arthritis symptoms, or there is any other orthopedic problem to the joint. We have to rule out and then we have to proceed with our management. Next slide. Yes. So I think most of them will be sleeping now in the sleepy mode. See, come on. Next, we are entering into the management. So be fresh up and concentrate on the management. So dear students, I'm going to give a very brief overview about the management. Next, doctor. Next slide about the management. So management is generally based on the stage of the dysfunction, as I told you. So generally, as a first step, we'll follow as any soft tissue injury, we'll give proper ice and rice care. That is rice steps we'll follow. And we can ask him to switch on to some of the low impact exercises like swimming and bicycling. So that we can do some simple analgesics and some paracetamol and some non-steroidal antifibrillary drugs is also given. So as the deformity progresses, we will go for some orthotics and braces. Next slide. So stage 1, the posterior tibialis tendon dysfunction, what is the major treatment? So the thing is non-operative treatment is the major thing. So this includes the elimination of the clinical symptoms. So there are non-steroidal and anti-inflammatory medicine drugs, and we will go for some non-surgical treatment. So generally we will try for 3 to 4 months, and then we will give the patient prescribed an AFO, that is ankle foot orthosis with acute, who have the tenosynovitis for few days, immobilized, and then we will give rest to the tendon. Next slide. So I think here we have to focus more. This is about the physiotherapy management. So we have to emphasis on the strength training of the posterior tibialis tendon. So we'll do more of recruitment. And the secondary emphasis is given to the peroneus longus brevis and tendon, and then strengthening exercises to gastrocnemius and other intrinsic muscles. So our focus will be for the strengthening and the stretching of these various muscles, which are the component. So I will show you some of the exercises as a quick review. You can go to next slide. So this is one of the important exercise. So in the initial visit, we'll start with the soul to soul exercises in various positions, in high sitting and in the floor. In the sitting positions, we will go to keep the floor to drain both the posterior tibialis muscle. Next slide. Heel rise exercises. So you can do as we discussed, this is one of the important exercises. So this is one of the important exercise prescribed for the patient. So you can do in sitting or in the standing position, both is done. So healing raise on and down. Next slide. So strengthening, we can use various TheraBand exercises to strengthen, especially the plantar flexors, dorsiflexors, and the other important muscles of inverters and everters all over the foot. So which is very important strengthening exercise. Next. Stretching. Gastrocnemius stretching is very important. So we'll teach the patients active stretching. So it's very important exercises. So Achilles tendon, as you know, there is more chances for the tightening of this tendon. We are going to teach the stretching exercises. Next slide. So I think these all are videos which is associated with this. I put all the videos of this. So it will be like a movement. So intrinsic foot exercises, you all are very familiar with that, rolling the ball on the foot and collecting the foot muscle exercises, which all are very important. So these exercises is very important for the intrinsic muscles. So we have to train the patients with these exercises. Next slide. Collecting the pebbles and collecting and putting the objects in the cup. This is one of the important exercise. Next. Next is the progression of the exercises. So same way, and the phase 2, again, we have to do progress that single leg heel raising. Before we were doing that with both the heels together. Now we are progressing it to single heel raise, which is one of the important exercise. Next slide. This is one of the important exercise, which will be very effective for the people, that double leg heel raise while squeezing a tennis ball, which will actively encourages the rear foot curve. So we have to hold the tennis ball and try to raise the heel with maintaining the heel in the position. So this is very important. This will correct the foot eversion. Next slide. Toe walking. So walk on the toes. So begin with the 30 feet to up to 300 feet. We can keep the pressure through the ball of the foot, and then we can start the patient. You can train them in walking session. Next. This is one of the important exercise, like arch strengthening, like a caterpillar exercise. So what we are going to do is here, so we will be in a position of supine lying with knees bent, and just now keep the foot just apart from your buttock, both the heels. Try to lift both your foot arches and slowly pull your toes back towards the heel, and then relax your arches and then slide your foot backwards. So like that, slowly our aim will be, we'll be trying to foot closer to the our buttock area. But the thing is, we are going to raise the arch and maintain and relax it. This is called as arch strengthening caterpillar exercises, which is one of the common clinical they are using in the clinical practice for the posterior tibialis dysfunction patients. Next slide. Apart from strengthening, so we have seen various types of strengthening exercises. Balance training is also one of the important thing. We have to train them with the proprioception training, so to avoid recurrent injuries. This is also one of the important training for these patients. Next slide. So in the phase 2 progression, we have to continue with all the earlier exercises, and you have to use a correct clinical judgment to complete the functional and return to the sport program. It's very important because sporting, making them again, there are many researchers that even many sport persons are getting this kind of posterior tibialis dysfunction. So our main aim will be to make them participate in the sport activities. Next slide. So this is a slide video which we have attended, that is short foot exercises. So here also what we are going to do is, it's like same like intrinsic foot exercises, but we are going to isolate the contraction of the plantar muscle. So what we are going to do is, we will not raise our heel, or we will not raise the head of the metatarsal. So by keeping it resting on the floor, we will just try to, we will not move our toes, whether in flexion or in extension. We'll try to shorten the toe by using the plantar intrinsic muscle. So this leads lot of training where we will try to use the intrinsic muscle by lifting the arch without lifting the heel and your balls of your metatarsal toe. So it's very what's a fine exercises which we need to train the patient to do it correctly. So this foot core training is one of the best exercises for the tibialis posterior dysfunction patients. Next slide. So as we are now, the Kinesio taping is very popular. They say that this will help us in the healing process. So some of the tibialis tendon dysfunction, there are some studies who have proved with the K taping. So I just want to tell you the brief ways how to put. So generally we use the K taping without any much stretch. We'll cover the medial border of the foot as a step 1. Next slide. In step 2, we will just add another strip, eye strip behind the medial malleolus. So I can show you the picture in the next slide. Kindly change it to the next slide. Next slide, please. Yeah, so this is about the next step where we will put in the behind the medial malleolus another eye strip, which will provide. So this is important. Your foot will be kept in dorsiflexion and inversion. Next slide, please. So if the dysfunction, or if you feel have more symptoms, if you feel that you need more reinforcement, we can give one more stab in the same position behind the medial malleolus. So this is a simple way of using the case tape, which is effective for the patients. Next step. Next slide. So now we have seen the initial stage 1. So as I told you in the beginning, stage 1, we physical therapists have major roles. We have seen lot of exercises. So now the next thing is stage 2. In stage 2, non-surgical treatment involves mainly the orthotic devices. So I will show you some of the important devices which can be used. That is especially the University of California, Berkeley robotic orthosis. So this is one of the best orthoses which can be used for correcting the deformity. Can you go to the next slide? I can show you the picture of this orthosis. See, this is a typical orthosis to correct the, especially for the heel. And same way, we can use the short lace leather AFO. So these all are especially used in case of the stage 2 dysfunction stages. Next slide. I think we'll coming to the end of this. So this is one of the important orthosis AFO, which with T-strap, which is also commonly used in stage 2. Next slide. So this shoe modification, you all are familiar with the medial wedge, and same way the medial flare. This is also one of the important. This 2 modification can be given to the patients with stage 2. Next. So this stage 2 surgical treatment. So if there is a large gap, so if there is a gap present in the posterior tendon, then in stage 2, it is more like tendon transplant, and it's for the tendon surgery. So generally they will if there is any injury from the navicular, they try to drill it and they try to fix it. So even the other type of surgery is to transfer the flexor digitorum longus tendon through the heel roll in the navicular, and it required for its insertion. So this is one of the important tendon surgery done in this stage. And sometimes they'll go for other types of surgeries like osteotomy and double or triple arthrodesis, and even the lateral column lengthening to recreate the medial longitudinal arch is also one of the important surgical treatment. And next is stage 3. Next slide, please. In stage 3, there will be a fixed deformity, and generally it is not passively correctable, because as in stages earlier, we saw there is a fixed deformity. So the non-operative treatment will need to accommodate the deformity. So we generally use the custom foot orthosis and the shoes in this to alleviate the pain. And as the deformity is not passively correctable, the tendon reconstruction alone is not helpful. And to correct the deformity, we'll go for some orthodesis surgery. And stage 4. So as I said, stage 4, we have more degenerative changes and more deformity. So definitely we have to go for the surgery, that is especially fusion. You can see the pictures, various types of fusion are there. So this surgical treatment involves the plantar fusion and high foot orthodesis, combining with the bracing. So this is one of the, say we'll do triple arthrodesis with the complete fusion of the joint in cases for improving the function. So I think we have seen for all the 4 stages. In that, as I said, stage 1, stage 2, we physical therapists have more role. Stage 3 and stage 4, I think we'll do most of post-operative physical therapy thing for strengthening and for relaxing. But the focus is, if you correctly identify and tackle the patient in stage 1 and stage 2, you can prevent them from going to the deformity of acquired flat foot. So that is the major idea of this presentation. So I'm going to conclude this presentation. Next slide. So with this, I want to emphasize that posterior tibial dysfunction is a slow and onset condition and may complain of pain and swelling around the medial ankle. General examination may reveal tenderness in the course of the tendon and difficulty in performing a single heel raise. So I told you it has a very good sensitivity, this test. So you can do the single heel raise and there will be presence of too many toes sign. So this too is a very, very classical sign for this posterior tibial tendon function. This will help us to pick up the case easily from other foot problems. The posterior tibial tendon dysfunction as an entity is usually under-recognized still, and early stages of disease can be misdiagnosed. So that is what I told you. So prompt physiotherapy treatment can prevent deformity and the need for surgery. So we are going to help the patient to avoid the surgery. So next slide. So as a physical therapist, it is our focus. So today we have seen a lot of thing about the foot. So I want to conclude my presentation and I want to thank the organizing team for giving me this opportunity. So I want to say that always don't follow in any footprints, because we are going to read the foot markers and other thing. Make your own footprints. So as a students, you are the future citizens. So you are the future of tomorrow. So please always check any conditions and don't miss anything, so that the patient will not get affected. So that is my point today. So I want to thank all the organizers for this wonderful opportunity. And I want to conclude my presentation with my salute to General Bipin Rawat. Today, we all know what a sad thing happened. So my salute as a behalf of all our as a citizen. So thanks for this wonderful opportunity. Thank you, sir.
Thank you, Professor, for your detailed speech on the posterior tibial dysfunction. I think
I know I've given an overview, so still I think we can explain each part still more and more.
We cannot see the overview. I think you are delivered detailedly on posterior tibial dysfunction. So
Yes.
even though it's a hidden factors, most of the children might facing the difficulty because they started playing only through the hands, not with the legs. So all the childs right now, they are developing test planners every day. So
you're perfectly true, because nowadays children are not going and playing in the sand. So we are not giving the proper exercises for your intrinsic muscles of the foot. So you're perfectly, your point is true, I think. And more important, why I took this topic is, if you see many systematic reviews, very narrative reviews, we have very less focus by the physical therapist in this area. So it is a very good area for all of us to explore.
Thank you, Professor. Thank you, Professor.
Thank you. Thanks for the opportunity. Thank you.
Thank you, Doctor. Thank you.
Good luck.
Good morning, one and all. A very fine morning. So next, I would like to call upon Dr. Arvindan. Arvindan, can you hear me?
Yes, sir. Sir, can you hear me, sir? Good morning,
Yes,
sir.
we are hearing you. Thank you, Dr.
Thanks, sir.
Arvind, for joining with us for the webinar
Yes, sir.
right